Well, good morning. It's so nice to see you here, and it's so nice to finally have this conference in the Fort Worth, Dallas area. This conference has been 4 years in the planning on our master plan, and it's taken us this long to finally do this. And this is because a private family stepped up and said, we need a conference in this area, and so that's why this conference is here. Before we begin, I want to thank and give a round of applause to our presenters who truly have come from very far away to be here. Anthony Bateman came from London, spent 4 days just to be here with us today. John Oldham is on his way back from Chicago and heading home, so he also went out of his way. And we have Glenn Gabbard, who is on his way to New Hampshire. So you see that each one of our presenters has really extended themselves beyond the call of duty. So thank you to Glenn, too. It's now my pleasure to introduce Dr. Peter Kowalski, who will be our moderator for the day. Thank you.
Thank you, Dr. Hoffman. I won't spend too much time. I first would like to cover some announcements. We will not have a first break for today. We will proceed with Dr. Oldham's lecture and then to Dr. Gabbard's. If everyone would turn on or put pagers and cell phones on vibrate, we would greatly appreciate it. This conference is being videotaped, so if you will, please do not walk in front of the video cameras. We also will have written questions to be submitted before the interactive panel, and we will pass out the cards to submit the questions before the panel. Perry, will that be at the second break? Or the 10:45 break is when we'll pass those out. So look forward to that. I also want to thank our participants in this conference. This would not be possible without the generosity and support of people here in this community who recognize the need to expand our understanding of this disorder and to break out of the mold of thinking of things in a conventional fashion and to be able to understand the different levels at which we can intervene in our treatment endeavors to help patients and help their families. I appreciate the support from my colleagues here in this community, and I appreciate the friendships that have lasted through the years from my colleagues from both here in Fort Worth at Menninger Clinic and from my new friends at NEA.BPD, and I hope that this will be a fruitful and enduring relationship for our community. I would like to turn this over to Dr. Oldham, but before I do that, I'd like to introduce him. He has recently joined our community in Texas here by becoming the Senior Vice President and Chief of Staff at the Menninger Clinic in Houston. He has an illustrious background and has compiled a wonderful textbook on personality disorders, which we just spoke about just prior to before this conference. Before that time, he was the professor and chairman of psychiatry at the Medical University of South Carolina, and in New York as well. He has a lot to say about his topic of charting the future for borderline personality. And with that, I'd like to have you come up here, Dr. Oldham.
Okay, there we go. All right. Well, it's a pleasure to be here, and I'm delighted always to be a participant in these conferences, and there have been a series of them throughout the country, but it's particularly wonderful for me to have this conference here in the Dallas-Fort Worth area. What Peter didn't say is that as a young lad and a young adult, I spent many years of my life as a Texan. So I went to junior high school in Dallas, then graduated from Lubbock High School, then lived in Amarillo, then went to Baylor Medical School in Houston, and then strayed for a while. But I saw the light and came back to Houston, and so it's really great to be back in Texas. I've been asked to start this conference, and what I plan to do is to do a little bit of setting the stage. We'll focus in on really, for the most part, the really wonderful progress and exciting developments in understanding patients with personality disorders, and particularly borderline personality disorder. But in order to get into that, and Glenn and Anthony will be telling you a lot in much more specifics about strategies for helping patients with these conditions, what I want to do is to put it in context a bit. So let's start out with what's pretty generally agreed now as a convention, that we use the words personality, character, and temperament to mean that personality has two major contributions or components. One is temperament, which is really the genetic, heritable contribution to personality. It used to be the old nature-nurture debate, which isn't really a debate anymore. We're clear that, at least for most of our personality disorders, we're very clear that there is a genetic component, a genetic risk factor that predisposes one to developing a personality disorder. And that's combined with the experience of environmental and developmental events that together produce and shape one's general personality styles and traits, but also what we call personality disorders. I'm going to talk a little bit more in a few minutes about how we think about these disorders and where we think the field is going. The best journal, actually, for personality types and disorders is the New Yorker magazine. I have a whole collection that if I had time we would enjoy, that really are wonderful. This is one of only a few I'm going to show you, and I put this up here to make a point. As you see, she's saying to him, "Why are you the way you are?" That's a fundamental question that we're right in the middle of when we talk about personality disorders. So you can translate that and say, she didn't ask him, "Why do you have what you have?" So is a personality disorder what you have, which might imply that you got it somehow, and could imply that you could get rid of it somehow? Or is it the way you are? And I'll also let you know that I probably won't satisfactorily answer that question by the time I stop, because it's a central debate, a central dialogue in the field, where we're really thinking about the continuous nature of these conditions we call personality disorders that almost seamlessly merge into and interact with normal traits and styles of personality. And we'll see some more data that will talk about that a little bit in a minute. This is not a new concept. This is from the 5th century BC. Many of you are aware of the model from the classification system of Hippocrates. This is not for any purpose other than just to illustrate that the observation that there are different personality types and styles has been around for a long time, but not just the observation, the theory that it correlates one's particular behavior and style with something in the body. In those days it was called a body humor, and you can see the body humors that were at the time thought to correlate with behavior types and styles. One of the things that we're now thinking about is is the system we use in the diagnostic manual the most appropriate way to think about these disorders. And that's the categorical system that's much more familiar to medicine and to the concept of illness. A dimensional system is what I was just talking about, and that is a continuous variable. So if you think about personality disorders dimensionally, you might think about them in what I sometimes call the hypertension model. We all have blood pressure. We need it. We couldn't live without it. But if we have too much of a good thing, it becomes a problem. It's a quantitative model. And you can think of the personality disorders as a sort of shorthand that way. It's not necessarily invariably the case, but it's a way of thinking about the disorders on a continuum. This is, again, part of what's being thought about as we approach revisiting how we're labeling these disorders and thinking about them. But there are a number of dimensional systems that have been proposed. These are just a few. I think this may be some of you may recognize, if you have been around as long as some of us, this name, otherwise known as Timothy Leary, and well known for, I think, some other aspects of his career. But he's actually a very respected clinical psychologist who was interested in personality and developed something called an interpersonal circumplex, which is a circular diagram so that you can be cold and distant on one side, warm and friendly on the other, and lots of polar opposites around the circle, and you can plot a personality type. So that's a set of different schemes like that. The three-factor model is a very well-known one. Psychology has been studying and interested in the field of personality for a long time. John Livesley has proposed a four-factor model, and Leanna Clark. The five-factor model, which is now called the Big Five, is probably the one that has the most consensus among the dimensional models, that proposes to cover pretty much the waterfront of personality functioning. And Bob Cloninger has developed a seven-factor model. This is the Big Five. It picks up on the Eysenck three factors, which is neuroticism, extroversion, openness to experience, agreeableness, and conscientiousness, are the fourth and fifth factors of this scheme. And again, this is something that can be translated into DSM language, but it's very difficult to take this to the bedside, to take it to the consulting room, and to use this at a clinical level comfortably. And whether this is something that will gain traction as we think about DSM-5 has yet to be determined. This is the first version of Bob Cloninger's model. And I put it on here just to show you that it's an interesting, more recent proposal. And this proposal has three what are called brain systems: behavioral activation, inhibition, and maintenance, that are correlated with personality dimensions of novelty seeking, harm avoidance, and reward dependence. And the proposal here is that these are critically affected by the levels of the principal monoamine neurotransmitter, in this case dopamine, serotonin, and norepinephrine. So you see, these are our body humors that we're talking about now, although we think we're a little closer to the real science involved. Then there are relevant stimuli and behavioral responses. What Bob did was then suggest there may be a fourth factor that is persistence, and that these four are moderately heritable. This would be the temperament domain. And there were three others that he called self-directedness, cooperativeness, and self-transcendence, which are the character domains, which are the domains that are shaped and built in the context of development and environmental experience. If you had an on-off switch, and Bob has developed something that's a self-assessment instrument called the Temperament Character Inventory, and you took it and you had anybody with a lot of self-directedness, it's very unlikely that that person will have a diagnosable personality disorder. If that person had very low self-directedness, it is much more likely. And the next closest to that is cooperativeness. Those are two pretty good screens for whether there's personality pathology. Well, what have we done in psychiatry? I apologize for the busyness of this slide, but people sometimes think that we didn't really think much about personality disorders until DSM-3 came along, which was in 1980, at which time there was the development of the categorical system. The personality disorders were put in a multi-axial system on axis 2, and we developed criteria to define the personality disorders. But actually, in every edition of the diagnostic manual, ever since the first one in DSM-1, and actually DSM-1 was created with an interesting history. I'm not sure that everyone is always aware of that. In 1943, the U.S. War Department commissioned a group of scientists and clinicians to develop a classification system for mental disorders that was really directly in the context of World War II, and was proposed as a need to deal with personality disorders for troops under stress. It's an interesting origin of the whole diagnostic system, especially to think about now when we have so many returning troops exactly in that same category. That led to the American Psychiatric Association setting up its Committee on Nomenclature to develop the first version of what later became in 1952 an adopted and endorsed first diagnostic manual. And what you see here is personality disorders were very much identified at that time. Here, they thought there were personality pattern disturbances, personality trait disturbances, and pattern disturbances were thought to be pretty durable, unresponsive to treatment, and unlikely to change. Trait disturbances were thought to be a little bit more environmental reactive. And look at one of them, emotionally unstable, which is actually one of the terms that's recently been proposed for borderline. So what we see is different labels, but probably some very clearly overlapping kinds of symptom pictures. Some disorders are in every single edition. Paranoid marches right across the screen. Some of them were proposed and dropped. Inadequate personality, we don't talk about anymore. Asthenic, antisocial has been in all of the editions, but explosive went to axis 1. And then some disorders were first introduced in 1980 in the DSM-3 system, and that's where we see borderline appear for the first time. But many precursors are in the clinical literature that clearly overlap with borderline personality disorder, things like pseudoneurotic schizophrenia, latent schizophrenia, ambulatory schizophrenia, psychotic character. There are a whole series of labels that would probably overlap with what we now try to define as borderline disorder. Here's what we have, of course, as you know well, in the current diagnostic manual. 10 disorders, and then there are a couple of others on the in the appendix, one of which is passive-aggressive, and the other is a proposed disorder called depressive personality disorder. You see that there's an element of dimensionality here. So these disorders have been clustered, and the cluster A group are called the odd eccentric group of personality disorders, paranoid, schizotypal, and schizoid. Cluster B are called the dramatic, emotional, or I would add impulsive, and those are antisocial, borderline, histrionic, and narcissistic. And cluster C, the anxious, fearful disorders. So we've already tried to sort of group these in a way that emphasizes the similarities of some that will differentiate them from others. There's one other category called personality disorder not otherwise specified, a very awkward term, but somehow it's in there, and it gets talked about in shorthand as PDNOS. If you go to clinical charts in hospitals, like if you went to Menninger and just went to the records, it would be probable that you would find a fair number of patients diagnosed with PDNOS, and there have been studies that show that. I'm going to get back to that in a minute, because that's probably, when you see that, not being used appropriately. In order to diagnose a patient with PDNOS, a patient has to have, in your opinion, the fundamental features and be suffering from a personality disorder, but not meet the diagnostic threshold of any of the 10 disorders. So people sometimes think it means mixed personality disorder, that you've got several of them. It doesn't. If you're at threshold or above, you should put the label down of what you're at threshold or above for and not use that one. Well, how do we sort of put together styles and traits with disorders? A book I wrote with a colleague, Lois Morris, the only time I wrote a book that was not for the scientific world but was for the public general readership, was this one. It's a book that's published by Bantam. And I used this model that we talked about, the quantitative model, and looked at all of the diagnosed personality disorders at the time, and this was first published in 1990. And then, in essence, used the diagnostic criteria, conceptually kind of turned the volume down until what we called a disorder was then an adaptive style, and cooked up some labels for those styles. That was a little challenging sometime. How do you figure an adaptive label for antisocial? But we came up with adventurous, and actually I think it works. Narcissistic was another one that was a little tricky, and we called that self-confident. And borderline we called mercurial. But this was just a way to try to get a handle on what would be, what you all know and we all know, the way we know people is from their, what we sometimes call individual fingerprints of personality. Everyone is unique. But this book has a self-assessment test in it. And the book has had a wonderfully marvelous shelf life. We did a second edition in '95, and it's still on the shelves at Barnes & Noble and Borders today. So it's been very much of interest. You can take the self-assessment test and then chart it. So here's an example where you have the styles along the bottom, and then you chart what's characteristic of you, and you can see at a glance what your typically more sort of prominent features may be and what's not particularly characteristic of you. I'll tell you a quick little funny story, and those of you who've heard me present before will have heard this, and have my apology, but this was a particular person named Joe G, who took this. Back in 1990 when the book came up, I was on the Today Show to push the book, and that was at a time when Bryant Gumbel, Deborah Norville, and Joe Garagiola co-hosted the show. This is Joe. What was even sort of more interesting was you can tell about people sometimes even before you look at their test results. So Joe took the test, we put it on the screen live and talked about it. Deborah Norville took the book to the back room, took the test, and wouldn't show anybody. And Brian Gumbel wouldn't touch the book. I'm serious, he wouldn't. But he loved analyzing Joe, so we did this live on the screen, and it was interesting. So, but this is an interesting chart. So it just shows you how it can work. So vigilant, we actually call that our New York style. I don't know what we would call a Texas style. We call leisurely our California style. But, you know, he's high on that. He's high on dramatic, which is not at all surprising. Somebody who was a professional ball player, loves to be on the camera in front of the media. That's fairly typical. Aggressive is also not at all surprising, and Gumbel was particularly taken by that because he said those who knew Joe would understand that that was correct, and I don't know what he was talking about. But if you're a professional ball player, you've got to have a fair amount of that. The one that surprised me was the high on devoted right here, which seems a little odd in combination with aggressive and vigilant. I learned later that when he was a professional ball player, Joe's nickname was Mr. Loyalty. And there it is, and you see it. So it's really an interesting way. Now, what I deliberately did not do was draw a line across here and say above that line is abnormal and below it is normal. Because it doesn't work so easily that way. And that's a real challenge for us, actually, because even in the DSM system, we define what's abnormal with a threshold, or what's called a cut point. Who says that it's 5 out of 9, for example, criteria that define you as borderline. A committee said that, and you hope it's good judgment, and I think it was a serious, careful effort to do so. But it's relatively arbitrary in many ways. So we'll think about that in a minute. Now, in the DSM, and a lot of this is familiar to you, but I put it on quickly just to remind us, there is a generic definition of the personality disorders. And the reason I put this on here is because we are rethinking this based on new data that are really challenging some of our notions of personality essentials. But as we define it in DSM-4, you've got to have at least 2 problems in these areas: thinking, emotions and affect, interpersonal functioning, and impulse control. It's also got to be enduring, pervasive, and inflexible across a broad range of situations. It also leads to clinically significant distress or impairment in functioning. And we haven't paid enough attention to functioning impairment, and we'll talk about that again in a minute. It also is stable and of long duration, and its onset can be traced back to adolescence or early adulthood. It also is not better accounted for as a manifestation or consequence of another mental disorder. And it's not a direct physiological effect of alcohol or drugs. When I was working at Cornell many years ago, and we developed the first semi-structured interview for all Axis II disorders that was called the Personality Disorders Examination. Armin Loringer was the main architect of that, and I was fortunate to collaborate with him. We got it all done and went out to sort of road test this condition. And I'll tell you 2 different examples that were among the early patients that I talked to and interviewed using this assessment system. All of these interviews start with a kind of STEM presentation. So you say to the patient, I really appreciate your time and that you're willing to spend some time with me answering some questions, and I'm going to ask you a series of questions. And what I'm really interested in is what you are like most of your adult life. I'm not really interested in what's only been characteristic of you at really high times of stress, or when you've been, if you have, struggling with things like alcohol use or other kinds of situations like that. I really want to know what's typical of you. So one of the early patients I talked to who was in the hospital, this was at New York Hospital, said, "Stop." And I said, "Okay." And she said, "Well, I'm 35 years old, and I'm here for treatment of alcoholism. Severe. And it's the first time I've ever been willing to come into treatment. And the last time I was sober and not using alcohol extensively was when I was 12 years old." Well, I was stumped. Who is she? It doesn't fit. Who she is who she is while drinking, because that's her whole adult life. So you have to wait and see. If she's successful in maintaining sobriety, it would be very interesting to see who she becomes. And most of the instrument makers have ended up, again, with some degree of arbitrariness, just saying, okay, then tell me what you're like most of the time, the majority of the time, in the last 5 years. And we're going to use that as our definition of who you are. But it's a challenge. The second patient I interviewed, which isn't this point, but illustrates another one, we ended up scoring, and this person scored at or above threshold for 10 out of 11 DSM-3 disorders. So what did she have? Did she have 10 co-occurring, independent, separate personality disorders? No. You're shaking your head. I shook my head, too. It doesn't make any sense, does it? So what does she have? Well, I guess you'd say she has bad personality disorder. Or a lot of it, or severe, or extreme. So what that illustrates, again, is that we have a somewhat arbitrary convention that we've adopted, which is we've got these labels and think of them as separate categories. But when a patient has more than one and they start to add up, it really isn't a bunch of separate independent things. It's a disabling personality picture that is quite serious. And that's been a problem in terms of how we use the diagnostic manual. And I'll show you in a minute a proposal that Andy Skodel, a colleague, and I have made as one idea that is being thought about as we move to DSM-5, which is now a process that has just begun. How prevalent are these disorders? Well, there are not a lot of good data, but one of the best studies was by Torgerson, and that showed that in a very large community sample of over 2,000 citizens, now this is a door-to-door sample, not a patient population sample. Look at that, 13% of the population had personality disorders. That's high. What's the prevalence of schizophrenia? 1%. Now that's not a fair comparison because this is a whole group of disorders. And you might say, what's the prevalence that would be comparable? That would be of the group of psychotic disorders. So let's look at what the individual disorders look like. Here they are. Anything surprise you on this slide? Just scan it quickly. Anybody? Shout it out. Avoidant. Look at that. 5% of the population had avoidant personality disorder. So you want to know what the catch is? The catch is that this was done in Oslo, Norway. And actually, Torgerson talks about this in the paper where these data are presented in the archives, that he suspects that that's a reflection of what really is the temperament, the sort of northern kind of reserved temperament of the Nordic type. And that's certainly, in your minds and mine, different from the Germanic type, different from the Latin type. So we do see those kinds of geographic and cultural influences, and we haven't quite figured out how to understand that. What Torgerson then did was to look at where are other studies, and this is in the chapter of the book that Peter was talking about that Torgerson wrote. And there were several other studies that are not terribly ideal for pooling here because these are really not population studies. They're studies of family members and of patient-identified populations. But they were some, at least, approximation. And if you look then at prevalence, these are a lot of numbers, but just go back to avoidant, it drops down to a median of 1.35 or a mean of 2.9 if you pool it with studies, most of which were done in this country, and only one other outside of this country, which was in Germany. If you look at borderline, what you see is you're at 1.45 for the median, or 1.16. And it's usually referred to in the literature as having a prevalence of between 1 and 2%. More recent work has shown that may be a little bit lower. Mark Lenzenweger has written some about that. And it may be around 1%. Now, in the diagnostic manual, we have a multi-axial system. So some disorders are diagnosed on axis 1 and some on axis 2. I'm going to get back to that when we're thinking about DSM-5, because why did we do that? Why did we put the personality disorders on axis 2? Well, there's a lot of uncertainty about that. If you go and look at what the fine print says in the diagnostic manual, it says that these are disorders that are pretty much like that generic definition, viewed as enduring, characteristic, and long-term, stable and persistent, and lasting over time. Frankly, I think it was also a residue of a long-time prior way of thinking, which was that character pathology was sort of psychological, psychogenic, not biological, not episodic, like episodes of depression or episodes of mania or episodes of psychosis. Those were thought to be biologic. That was pretty much what axis 1 meant. And axis 2 was sort of psychogenic. It wasn't stated, and nobody would defend that, but I think that was part of the influence that contributed to that decision. Again, we'll talk about that a little bit more in a minute because I think there's a lot of revisiting and question about that. But again, a busy slide, but just to make a point, this is from Larry Seaver and Ken Davis, which says, okay, you could use a spectrum model. You could say, well, if we're going to have a multi-axial system, we're going to have DSM-2, axis 2 disorders in the DSM, we're going to leave them there. You could say, okay, some axis 1 disorders probably are correlated with some axis 2 disorders, maybe not all of them. But schizotypal, we know actually, and good data exists now to be very clear, that this is what's called a schizophrenia spectrum illness. You have a certain inheritable risk to develop schizophrenia that may be an insufficient amount of risk for you to be vulnerable to develop the full-blown schizophrenic condition, but you may have a schizotypal personality style. Notice that borderline is on two different dimensions, impulsivity and affective instability. And those are both features of borderline. So it's something that shows up in both of those. And then, for example, on the anxiety cluster, you may see avoidant personality disorder. And I'm not sure we do have good data that differentiate that from phobic anxiety disorders on axis 1. So let's move then and talk about borderline for a little bit. And then I'll come back in the end and just say a word or two about where we think the field is going as we're thinking in the early process of DSM-5. Now, you know the borderline criteria. I won't go through them. I just put this on here to remind you that number 9, transient stress-induced paranoid ideation or severe dissociative symptoms, was new with DSM-4. It was added in that manual. It wasn't in the previous manuals. There was a big debate when DSM-3 developed criteria as to whether transient psychotic episodes should be included as a criterion for borderline PD. At the time, I remember Otto Kernberg and John Gunderson both strongly favoring the inclusion of that criterion, but in the end, the decision was made not to include it. In some ways, that helped differentiate schizotypal from the borderline definition. The term borderline originally, based on work of people like Grinker and some of the early researchers, was thought to be on the border between the psychoses and what at the time were called the neuroses. So that's where the sort of notion of borderline came from, or at least one way it was thought about. But we've clearly established that it's not a schizophrenia spectrum disorder. This tilts it a little bit back in the direction of overlap with the schizotypal, but just a little. Oops. Now, this is not one thing. Look at this. DSM-4 defined borderline personality disorder is thought to be a well-defined clinical syndrome. But because it's a polythetic system, and because you can have any 5 out of 9, those who know how to do that and did the math told me that there are actually officially 256 different combinations of those criteria that officially can define you at threshold for this disorder. So we have actually a population within a definition. And this is one thing that troubles me a bit in the literature, because when you see careful studies of borderline pathology and one doesn't replicate another and they're not consistent with each other, I don't think there's been enough attention to whether the populations are the same, because you can have very different groups of borderline patients and still have them all officially with the diagnosis. Another way we can think about these disorders is on the basis of what we now know, which is the heritability contribution to borderline personality disorder. We had a big conference in New York about 6 or 7 months ago, which was to look at personality disorders from the point of view of endophenotypes. Now, what do endophenotypes mean? Well, phenotype means just what you see behavior. So patterns of behavior and symptoms that are defined by the criteria is the phenotype. So a phenotype of borderline is a patient who is impulsive, emotionally unstable, has difficult and problem-ridden interpersonal relationships, and self-injurious behavior, and the kinds of things that describe the behavior of the patient. Endophenotype really means what emerges from the genetic risk factors that then becomes the engine that drives that behavior that we describe as the phenotype. So what's the endophenotypes, or what the internal motors are that are driving that behavior. Now, they may be there and not turned on. So you can have a certain genetic risk, which you can conceptually think of as attached to a couple of forces that have not been activated. But if you're under stress and that activates those forces, turns on those engines, the genetic risk factors, you will then have impulsive aggression and or affect dysregulation as two of maybe more sort of driving forces that then produce the behavior. So it's a way to think about what's the essence of what we think is happening biologically and genetically that is, at least to that degree, contributing to the behavior. And the whole conference was an attempt to look at what this way of thinking could lead to in terms of guiding treatment and guiding our understanding of the neurobiology of these disorders. We do think borderline does have heritable features. Torgerson himself has done one study, a twin study, that suggests that, and other studies suggest it in a less specific way. So Cloninger has shown clearly a genetic contribution to what's called novelty seeking, which is a part of this cluster B type of behavior. And Larry Seaver and Antonia New have talked about impulsivity as well. Now, there are other things that do contribute to borderline pathology. Thomas Renna, who just chaired the program for the International Society of Personality Disorders, for the study of personality disorders, and that was a meeting held just about 2 weeks ago in the Netherlands, has done some work. And when we talk about the character or developmental or experiential contribution to borderline personality disorder, I think it's important to put it in the context of a very broad model, which is referred to as the stress vulnerability model. So all of us have susceptibility. You just say a word about that, because I think it's important to understand that this is not unique to borderline. It's true for almost all conditions. A colleague of mine at Columbia when I was in New York, Nancy Wexler, studies Huntington's disease, which is a very devastating and almost entirely fatal genetic dominant condition that doesn't surface until after your childbearing years. And so it's been a very terrible disease. But she's got interested in genetic counseling. So she likes to say to an audience like this, you know, it'll only be a matter of, I don't know, not too many years until nobody in this room will be insurable. And everyone wonders what she's talking about. And she says, well, you know, insurance companies will not insure you for pre-existing conditions. And your family is at risk for hypertension, yours for diabetes, yours for arthritis, yours for cancer, yours for depression, mine for schizophrenia, mine for borderline personality disorder. So that we all have these risk factors. If we're lucky and we've got not that high a level of risk vulnerability, or a moderate level, but we're lucky to land in a very supportive and nurturing environment and dodge major stress, just like you can have a risk factor for adult onset diabetes. But if you're an exercise nut and you watch your diet, you may never know it. But if you're not, you might. Same goes for borderline, and same goes for almost all medical illnesses, certainly hypertension, heart disease, all kinds of things. So we also know that stress exists and that there are family situations which can be terrible and can in fact be frankly abusive. So that's been studied. It's an overstatement by a lot to say that borderline personality disorder is caused by family abuse or mistreatment. That is not an accurate statement. There is a fairly frequent history of neglect or abuse in the histories of many patients with borderline, just like there is in patients with PTSD, patients with depression, patients with lots of other conditions. And in this study, the main thing that this showed was that sustained childhood abuse over a long time that was really severe and persistent did seem to be a critical factor, but it didn't necessarily just produce borderline. It could produce risk to depression or other kinds of illness. There have been brain imaging studies. I won't go through all of them, but just to tell you that that's happening. There are a lot of very interesting studies. You're going to hear from Glenn Gabbard next, and he and colleagues, Reed Montague and others at Baylor in Houston, are doing some very interesting brain imaging studies. The study's not finished, but it'll be really interesting to see what that shows. What mostly gets noticed in these studies is that we're talking about limbic system structures. And there's reduction in the volume of the hippocampus and of the amygdala. And it's clearly not just related to trauma, because it's not just in the group that has trauma that we see this. This is another study. Christian Schmal actually got an award at the meeting in The Hague, in the Netherlands, just last few weeks ago. He's done some really interesting work. But in that, again, shows this limbic volume reduction. There have been also PET studies that show frontal and prefrontal abnormalities, again showing some abnormalities in some limbic structures as well. So the implications are that we see abnormalities in the frontal cortex and in the limbic networks. Now what does that mean? Frontal cortex is really what controls your cognitive, thinking, cerebral abilities. And in essence, what you can think of it as, I'm using these metaphors, but they're handy sometimes. The limbic system is the motor of the car. If you're talking about impulsivity and affect emotions, the cortical system is the brakes. So if you've got a predisposition to too much impulsivity and affectivity, but you've got a good brake system, you can keep it under control. If the brakes don't work very well, you've got a V8 motor, you're going to have trouble. There are also these neurocognitive deficits that have been noticed, which are a probable correlate to those cortical abnormalities that we're beginning to see. So it's hard to make reasonable choices. There's a disinhibition pattern that is seen, and having trouble doing some planning as well. Attentional mechanisms are difficult. Michael Posner did this work and looked really at a reduction in cognitive control. They referred to this as sometimes effortful control. That means if you and I have an impulse to do something that's probably not very wise, such as to take off from work and go to the zoo or whatever in the world you're in the mood to do, you can usually overcome it and stay at your desk. But if you haven't got very good control, then you'll sometimes do things that don't serve you very well in your capacity to function. This is a more recent work by Heather Boleyn and others in the United Kingdom, which looks at borderline patients and compares them to patients who had lesions in the orbitofrontal cortex from stroke, and they were very similar. So we saw, again, just from a completely different population, that that area of the brain seems to be affected. It contributes, or it may have some borderline contribution, but not all, because other parts of the brain that were affected by stroke didn't show this kind of borderline-like behavior. All right, now let me move into talking about what happens in borderlines as we're beginning to understand them better through careful studies longitudinally over time. This is called the CLIP study, or the Collaborative Longitudinal Study of Personality Disorders. And this is an NIMH-funded study that is now in its 11th year of funding. It's a naturalistic study that follows patients longitudinally over time, carefully evaluating them every 6 months after a very robust and intensive structured evaluation at intake. It's not a treatment study. A lot of these patients are in treatment of various kinds in the course of the follow-along, but we're just trying to look at what happens. There are very comparable studies like this that Marty Keller did for depression over time, and a similar study for schizophrenia that has been followed over time, and it really informs us a lot about what really is going on with these patients. This was the New York team at the time. Donna Bender and Andy Skodel and I Subsequently, Andy took over the lead for the whole group. Originally, it was led by John Gunderson, and it's still underway. And we had these 5 sites, as you can see, almost 700 patients. And here are the 5 groups that we picked. We had patients with schizotypal, that was a cluster A group, patients with borderline, a cluster B group, patients with avoidant, a cluster C group, and we tossed in patients with obsessive compulsive personality disorder because we didn't think anybody knew anything about these patients. And it was high time we figured out, is this even real? And then we had a control group, which was major depressive disorder. And for methodological reasons, this group had to be patients with major depression who did not also have co-occurring personality disorders. So guess which cell was the hardest to fill? That one. We couldn't find patients who had major depressive disorder, and when you systematically gave a semi-structured interview covering all of Axis 2, we're below threshold on all 10 disorders. So it was challenging. But we did find 95 of them. What did we find at intake? At the front door, we took a history about how much treatment these patients had already had. And this is outpatient treatment, so it includes self-help, family therapy, group therapy, individual therapy. And the winner is, if you can put it that way, borderline, reported having had the most treatment of any of the groups. What about inpatient or residential treatment, halfway hospital day treatment? Borderline had the most treatment experience. These are significantly disabled patients. That's not a news headline to you. We know it well. But it's important to have these data to be able to demonstrate that with some degree of confidence. What about medication use? This is a little harder slide to read, but one thing I would point out is that these data have been controlled for any co-occurring Axis 1 conditions. So what you see here is the medication history reported by borderline patients after the data have been controlled for any co-occurring depression. So the main point I would make here is that after you control for any co-occurring depression in borderline patients, they reported having used antidepressant medications more than patients with major depressive disorder. Does that mean that's appropriate treatment? Probably not, because we know that historically treatment of these patients has been pretty much all over the map. And it doesn't mean that it's not indicated, but it means that it's probably overused. I had the good fortune to chair the American Psychiatric Association practice guideline group that developed the practice guideline for the treatment of these disorders, and this was published in the American Journal in 2001. I would just say that 10 years before that, about 1991, was when the whole practice guideline operation got off the ground of the APA. And I was asked at that time to give a state of the science of what we knew about treating borderline patients. And at the time, we said, okay, we're going to do practice guidelines, but it looks like we're going to have what we call track 1 and track 2. Track 1 are the ones where we got a lot of research evidence, and that's how the process started. So we've got practice guidelines on major depression, on panic disorder, on eating disorder, on substance abuse, on all kinds of other things, and schizophrenia. But we didn't have very good evidence about personality disorders. We knew the need was there. We knew the patients were there, but we didn't have much research. And so we said, well, that's got to be track 2, and we're going to have to come up with a methodology to reach a clinical consensus about what the most of the experts agree is the best treatment. That sort of went on the back burner because we had all these others to do. 10 years later, lo and behold, we had some pretty good evidence. So we were able to use the same methodology that was used for all the others, and we didn't have to have track 2. And we developed the practice guideline. And the only practice guideline of the APA that exists where the primary or core treatment recommended from the evidence base is this one for borderline personality disorder. And the recommended treatment is psychotherapy with symptom-targeted adjunctive pharmacotherapy. So pharmacotherapy is useful, but it is not, in fact, the only or primary form of treatment. And the evidence that supported that you're going to hear more about, because Glenn's going to talk to you. And in your packet, you may have some slides there until Glenn and I got our act together and talked to each other, and I didn't want to present a redundant set of slides, and Glenn's going to go into treatment in some detail. But I will just say that in anticipating it, one of the things we were delighted was that we had Marshall Linehan studies that supported the DBT treatment for borderline, but we also had Anthony Bateman and Peter Fonagy's work that Glenn is going to tell you a lot about, and Anthony will as well, which was a randomized controlled trial of a very different approach from dialectic behavior therapy. And we ended up not recommending a type of psychotherapy, but recommending psychotherapy, because we already had evidence that two very different types were very effective in treating this disorder. This is a guideline watch, which was an update to the guideline that was published in 2005, which sort of brought it a little bit closer to current data. But we know overall, and again, Glenn's going to talk about borderline treatment, but this is a paper that looked at personality disorders overall, and again said that psychodynamic therapy and cognitive therapy are effective in treatment of the personality disorders. And there's a pretty good body of evidence that supports that. I want to pause for just a minute, or just digress for a minute, and point out that I think an exciting frontier of research has to do now, and Glenn and Anthony and I were just chatting about this earlier, with the huge explosion of research in the neurosciences and the interest in advancing frontier of knowledge about the biology of behavior, which includes the biology of the unconscious. And I actually teach a course to residents that's called Psychotherapy, a Biological Treatment. And we're beginning to have pretty good data, and it's not at all surprising if you think about it, because it's a form of long-term learning and memory. And we know that there are cellular and molecular biological processes that establish the effectiveness of learning and memory. And that turns out to be highly relevant to psychotherapy. If you don't do it long enough, if you just drop in for a session or two, that may not suffice. But you wouldn't learn your homework very well if that's all you did either. You've got to really revisit it and work at it. But if you do, it can work. This is by actually a group of workers led by Eric Kandel at Columbia, who won the Nobel Prize in the year 2000 for his work on the molecular mechanisms of learning and memory. And he says psychotherapy can induce robust changes in brain function that are detectable with neuroimaging. And here's an example. These are called subtraction studies. And what you see, this was actually a study of treatment of an anxiety disorder using either 9 weeks of cognitive behavior therapy alone, no medication, or 9 weeks of citalopram alone, no psychotherapy. And it was a before and after subtraction. So these patients had a brain image done before they were treated, and then a brain image after 9 weeks of treatment. And what you see is significant change in the limbic regions in both cases. So psychotherapy alone produces biological change. And in fact, the Kandel group goes so far as to say identification of brain regions associated with deficits of impulse control in patients with borderline personality disorder may be useful to predict a patient's ability to respond to psychotherapy and to recover. Now that's a whole just major new way of thinking and a new cast of characters taking a look at what has been mostly in the clinical realm only before. So I think it's an exciting time. Okay, let me now finish. I've got a few more minutes, and we'll have lots of time on the panel for discussion and interaction. But let me just talk a little bit about where we're going. The DSM-5 committee has now been established by the American Psychiatric Association. David Kupfer, who's chairman of psychiatry at the University of Pittsburgh, is chairing the overall group. And there are a set of work groups that have now been set up to look at all of the areas of diagnostic pathology. For example, There are work groups with mood disorders. Jan Fawcett is going to chair that one. There are work groups with the anxiety disorders, with lots of Axis 1 conditions. And there's a work group on Axis 2, or the personality disorders. Andy Skodel, my colleague from Columbia, who's now in Phoenix, Arizona, is chairing that work group. I'm fortunate to be on that work group, and so we've already had a pre-meeting, and our first official meeting is actually in about 2 weeks in New York, where we're going to sit down and sort of launch this process. So what's the group challenged with? Okay. Well, why should we even maintain an Axis 1 and an Axis 2 division? What are the arguments? Well, for one thing, it's a tradition. It's brought a lot of attention to the personality disorders, and we don't want to lose that momentum. There are a lot of evidence also that patients with comorbid conditions respond differently than patients with independent conditions. And it would also help us maintain continuity of research. Here's an example of that difference. So these are patients showing remission. These are patients who had a personality disorder or more than one, and major depression, or major depression alone. And what you see is that almost 90% had a remission within 24 months if they only had depression, and only 60 to 70% had a remission if they had depression and personality disorders. So, in fact, it does make a difference. Why should we toss it? Maybe we shouldn't have Axis 2. Well, John Livesley, he and I did a debate on this in the Netherlands 2 weeks ago, and we've done that several times, and it's fun to do. But we're pretty much coming around to a consensus. I told him at the debate, when I was the first debater, that I had told John that I would agree with him that we were reaching a consensus, but I really did that just because I didn't want to humiliate him with another crushing defeat in the debate. But he had his rejoinder, as he always does. But, you know, he makes some good points here, that there really are fundamental differences in etiology you would need to see if you're really saying these conditions in Axis 2 are different. Like I said earlier, are these just psychogenic as opposed to genetic? Well, they're not. They're not differences. Are there different clinical courses? Well, why is the clinical course of the personality disorders any different than that of cyclothymia, of eating disorders, of other disorders on Axis 1? I guarantee you it's not, and I'll show you some final data on that. And there are a lot of other problems Drew Weston has talked about. It just doesn't add up. So what could we do? We could move the personality disorders wholesale, pick them up and plunk them in Axis 1, forget Axis 2. Actually, I would be okay with that. So you'd have the mood disorders, the anxiety disorders, the personality disorders. Have them there as a group. Still have to deal with the continuity and the dimensional problem, that how do you link this to normal styles and behavior. Or we could emphasize level of functioning. We could use a dimensional system. We could try to tinker with the existing system. Or we could, in fact, move some Axis 1 conditions onto Axis 2. All bets are open at this point. You've got this slide. I won't go through the details, but these just itemize some of the limits of the categorical model and the limits of the dimensional model. But the group that sort of started thinking about DSM-5 suggested that we really need a dimensional approach. And if we do it in personality disorders, we may have to do it in other areas such as depression and affective disorders, because we've got a lot of somewhat arbitrary boundaries about how we define those as well. So there were a bunch of proposals for dimensional models, and among those, Andy Skodel and I had suggested one, and I'll just show you that as one example. And this is one that is probably the least extensive, and I'm not sure I would even recommend it. But it's a way that you could try to introduce some dimensional thinking, a little more than we've done with a cluster system, into the personality disorders. So you could stratify and say, okay, let's evaluate each patient in each category and figure out whether there's none of it, or it's flat out full-blown, or it's somewhere in between, using these terms. Here's why it's so complicated. Because you've got 7 criteria for paranoid, 9 for borderline, 8 for dependent, and a different number out of the total for each of them. So it's not uniform, and it becomes very complicated to track that. But you could do it. So you could do it. You could say this. Okay, here are your instructions, hypothetically. A personality disorder traits or disorders can be identified by the number of criteria met. Add them up in each personality diagnosis, and then use this system to decide what it says. So continue your instructions. If a patient is at or above threshold for up to 2, the diagnosis or those 2 diagnoses are what you put down. We said here, if it's 3 or more, let's call it one thing. Let's say this patient has extensive personality disorder. This is that patient I was telling you about a minute ago with 10. And then you can say, characterized by A, B, and C, which are the at or above threshold ingredients, and by D, E, and F, which are associated features. If you had only one, and it's paranoid, this could either be absent, have traits, be subthreshold, 4 needed to be at threshold, or flat out at 7. But if you had extensive, characterized by at or above threshold for borderline, paranoid, and narcissistic, this patient could also be subthreshold for histrionic and have traits of schizotypal. So this would be a way to introduce the dimensional data and stay with the system we've got. Final point, and I'm about up to Glenn's time, but this is where I'm going to just stop in a minute with a couple of quick slides about what the CLIP study has shown following these patients over time. Now, first of all, look at this, and let's just look at borderline. What this shows is the percent of subjects remaining at the diagnostic threshold at 6 months and at 1 year. And if you look at borderline, at 6 months, only 60% of them remained at the diagnostic threshold, when all of them had been at the threshold at intake. At 1 year, less than 40% were at the diagnostic threshold. So these are supposed to be persistent and enduring over time. Here they're going away in a lot of patients. Do they come back? They probably fluctuate. So let's look at it a little bit differently. Let's turn the volume up of our criteria. Let's say, okay, you can't just not be at threshold. Let's say you can only, we'll call remission, that you have no more than 2 criteria for at least 2 consecutive months. And this is at 2 years. So 42% of borderlines had remitted, meaning they had no more than 2 criteria for at least 2 consecutive months. We'll turn it up some more. Let's say you can have no more than 2 criteria for a solid year. So one of these 2 years, almost 30% lost, all but 2 or less criteria. Roll it up to 4 years. At 4 years, if you say 2 criteria for 2 months, 62% had remitted. If you say no more than 2 criteria for at least a year, half of them had remitted within 4 years. So what we're seeing is a lot of situational and environmentally reactive changeability in symptom presentation and in patterns of pathology. Andy hypothetically suggested that the probability of relapse after 6 years for borderline using that most stringent criterion would be only at the level of about 7%. What happens when you look at functioning? Functioning actually stays relatively flat. So here's a 2-year chart, and you see borderline really doesn't change much in terms of functioning. These are the patients who get better in treatment. If you look at data like this, and Anthony, you may show this, or Glenn, you may as well, over time, and certainly in Marcia Linehan's studies, functioning doesn't respond as well as dropping below the diagnostic threshold and changing some types of behavior, particularly, say, in the Linehan group, self-injurious behavior. So when we go toward a new model of personality disorders, what we're concluding is that these disorders show pretty good consistency trait-wise over time. Functional impairment is pretty persistent over time. But defined by the DSM method, it's not consistent over time. We need to pay more attention to functional impairment. We need to understand those traits are more stable than the symptoms that are mixed in with traits in our criteria, because we think that they're really, as we define them now, hybrids of more stable traits and fluctuating symptomatic behaviors. Aggressive, impulsive aggression and affective instability that Seaver and his group talked about, you could think about dimensionally in this way. This is a way we could begin to think about a new model, which is that you've got these 2 endophenotypes, and you can combine that with insecure attachment, how would that work? It would be that either these are so strong that even reasonable caretaking efforts by families don't succeed very well, because these are very difficult temperamental kids. And so they can't really, the attachment process doesn't work right. Or these aren't that strong, but there's neglect or abuse or fragmentation in the family. And the two together lead to unstable interpersonal relationships. And this is one of the types of models that we're beginning to think about. Never mind that slide. This is from the conference in New York that was just using that as a way to conceptualize. So we've got to redefine the disorders, reconceptualize course of treatment. This is important, convey a more optimistic prognosis to our younger patients and their families, because there's a lot that can be done, and that's what you're going to hear about next. And this is my last slide, other than going back to two more cartoons. This is from Bruce Fole, and it's a hypothetical patient charted over time. This is a patient with intensity of pathology at age 15, charted to age 50. This patient had depression, impulsiveness, and self-centeredness. Depression had two major spikes of pathology, and impulsiveness gradually diminished over time, and self-centeredness, forget about it. So you got to pick your battles in working with these patients. And there may be things you don't like, but leave them alone. Let that be, and let's talk about what we can help. And finally, there are two other versions of dimensional and categorical approaches. This is a dimensional approach, as you can see. 49% LL Bean, 49% IBM, and 2% Whimsy. And this is a categorical approach, the four basic types. Glasses half full, glasses half empty, half full, no, wait, half empty, no, half, what was the question? And hey, I ordered a cheeseburger. So I'm done. And I took more time than I should, Glenn, but...